There's something about this disease and the way it attacks our loved ones that is so different than other diseases. It's such a shock. They're taken away from us in such insidious ways.
Creutzfeldt-Jakob disease is a mysterious, frightening, devastating illness with a relentlessly progressive course. These people all had it. This man became symptomatic shortly after his daughter died of CJD, so he knew what the diagnosis meant.
I thought, I would hang by my toenails for 17 years if that wasn't true, but it is true. So it's nothing I can do about it to stop it. And I guess that's the hardest part, not being able to stop it.
We need to know more about CJD, how it occurs, how to make the diagnosis, and how to respond when a patient has it. These people have all lost loved ones to Creutzfeldt-Jakob disease, and we can learn from their experiences.
So it started out with vision, and then it progressed into motor skills. And from September, October, it kept going. He stopped driving. He started wearing sunglasses because everything was too bright.
We had no clue what was happening. We just knew that he was complaining about loss of vision and loss of memory. He would say, "I feel so stupid. I can't remember what I always used to remember."
Throughout the year of 2004, then she progressed downward. Not being able to walk properly, the gait changed, lost her cognitive skills.
He said, "I'm home from work, you need to find me a doctor." And I said, "What happened, Danny?" He said, "Well, I went to work and I worked all day yesterday and I came back today and it was all wrong and I don't remember anything I did."
And I'm telling you that every day that he would wake up and I would come down and we would sit together, I saw less and less of my husband there.
He looked at himself in the mirror and he said, "Don't they know what I've got?" And I said, "Well, they're still testing," and they were. And he said, "They must know something." And I said, "Well, they say you have a brain disease." He said, "Did I catch it?" And I said, "No, it's just in your brain." And he said, "How long have I got?"
Don't they know what I've got? They must know something. Did I catch it? How long have I got? These questions are difficult for physicians as well as for patients and their families. I'm Dr. Peter Ostrow, neuropathologist at the State University of New York at Buffalo and the Jacobs Neurological Institute. In this program, we'll explore Creutzfeldt-Jakob disease and the related disorders known as transmissible spongiform encephalopathies. Several experts have contributed to this production. Dr. Pierluigi Gambetti is director of the National Prion Disease Pathology Surveillance Center in Cleveland. He's also medical director of the CJD Foundation. Dr. Stanley Prusner is professor of neurology at the University of California in San Francisco. He received the Nobel Prize in 1997 for his discovery of prions and for elucidating their mode of action. Dr. Richard Johnson is Distinguished Service Professor of Neurology at Johns Hopkins. He chaired the Institute of Medicine committee that was charged with providing guidance for the National Prion Disease Research Program. Dr. Richard Knight is Director of the United Kingdom's National CJD Surveillance Unit in Edinburgh, Scotland. Dr. Robert Will is Professor of Clinical Neurology at the University of Edinburgh, and he was the founding director of the UK's National CJD Surveillance Unit. Dr. H. Branch Coslett is Professor of Neurology and Chief of the Section of Cognitive Neurology at the University of Pennsylvania. These leaders in the field will provide a comprehensive consideration of prion disorders. We'll review the history of spongiform encephalopathies and how their transmission was first elucidated, and we'll illustrate how the prion hypothesis explains their pathogenesis. Clinical features and the uses and limitations of various diagnostic tests will be presented for the different forms of prion diseases, sporadic, familial, and acquired. We'll also look at the fear factor, the myths and misconceptions that surround these disorders, and the surveillance mechanisms that have been established to help safeguard public health. And we'll consider how the medical profession may best serve the needs of afflicted patients and their families, how to access the resources available for assistance and support, and how to submit specimens for diagnosis and research. We'll begin by exploring the characteristic clinical findings in patients with CJD.
And spirit, we thank you and wish you the very best in your retirement.
In March of 2003, Ed Seipert retired, and at his party, he made a brief speech that began like this.
I really had this thing hit me today, and it was kind of stunning. All of a sudden, I told Nancy, I drove right past our street on the way home. You kind of get yourself in a preoccupied mode. I hope this isn't one of these early senior moments or I'm hearing.
But maybe it was something worse. A couple of months later, a similar episode happened when they visited his mother for Mother's Day.
He was forgetful that weekend, and that was all that we noticed. He ended up leaving my Mother's Day card at home, and he left clothes down there. And as we drove home, he got off on the wrong off-ramp. And from that day on, every day he went downhill in some way.
Typically, the patients present in late middle age, usually out of the blue with a rapidly progressive dementing illness, usually associated with a range of other neurological signs, particularly ataxia and myoclonus. And the condition rapidly progresses, and it's this speed of progression that's so dramatic and which tends to differentiate from other forms of dementia, which are much more common.
Into the third week, when he didn't know which towel was his, when he began to get lost around the house, when he began to lose mobility in his left arm, I called the doctor and he sent us in through emergency, and we had a CT scan and more blood work done, and they came back normal.
In CJD, typically the CT brain scan is normal and the MRI scan shows a particular appearance in the majority of cases which is quite suggestive of the diagnosis.
Mr. Seipert had an MRI scan a week later which did have that suggestive appearance. Compared to a normal control, his FLAIR study showed hyperintensity in a ribbon-like distribution in the cortex as well as in the caudate and putamen. That appearance was also striking in the diffusion-weighted images, which is typically the case in CJD. He also had EEGs, which demonstrated generalized slowing with periodic, frontally dominant sharp wave activity, a pattern that's not diagnostic but is highly suggestive of spongiform encephalopathy. Ed Seipert died just 3 months after he retired. His presenting and predominant symptoms were cognitive. Approximately 40% of CJD patients present with rapidly progressive dementia. Another 40% have ataxic symptoms at the outset, and the remainder present with a combination. Tom first noticed difficulty while he was playing golf.
I could not guarantee how I was going to swing. I was all over the place.
That soon progressed to serious balance problems, along with cognitive impairment.
I had trouble falling down.
You had trouble with your legs.
Right, on my legs.
And you get mixed up. Do you get mixed up in your head?
When?
Anytime.
Sometimes I get mixed up in my head, yes.
And you see things sometimes? Do you see anything that other people don't see?
Once in a while.
And do you hear things that other people don't hear?
Oh, you would try me to be goofy.
No. No?
No, she's right. I probably hear things other people don't hear.
His 45-year-old daughter had died less than a year earlier and had a familial form of CJD. His primary care physician didn't know his daughter and had never seen a case of CJD, but he recognized that this was an unusual situation.
Most of the time I can diagnose dementias without having the help of a neurologist. I will ask for a consultation to confirm the diagnosis and help in management, but I see enough on a daily basis that I'm very comfortable recognizing it. This is a different picture.
We'll explore the detailed workup and differential diagnosis of CJD later in this program. But first, let's consider how prion diseases happen, the basic molecular abnormality, changes that occur in the brain, the ways prion disease may be transmitted, and the biologic explanation for the range of clinical presentations. Creutzfeldt-Jakob disease and Kuru in humans, scrapie in sheep, and bovine spongiform encephalopathy all share a common basic appearance under the microscope. There's a pronounced vacuolation in the gray matter, which at its most extreme causes the brain tissue to resemble a sponge. In the cerebral cortex at high magnification, the vacuolation may be seen within or adjacent to neuron cell bodies, or in the tissue between them, where it's found in distended axons or dendrites. The spaces aren't really empty. Electron microscopy reveals that they contain delicate strands of membranes. The spongiform change is not accompanied by an inflammatory response, but there is an intense proliferation of reactive astrocytes, these plump pink cells. Here they're shown in a section that has been stained for glial fibrillary acidic protein. The astrocyte cytoplasm and processes are stained dark brown. We don't know exactly how the spongy change develops, but years ago it drew attention to a possible link between the various spongiform encephalopathies.
I remember back in the early 60s, there was this idea that there were these spongiform pathology that might form a unit. And an young epidemiologist named Jake Brody, who was at this meeting, jokingly and very facetiously said, well, maybe it all started because some Scottish minister who came down as a missionary, who'd eaten mutton and gotten scrapey, came down to New Guinea and was eaten by the locals, who then started the epidemic of Kuru. Now, he made this thinking he was being funny. The fact is, in retrospect now, most people think that Kuru probably did start as a spontaneous case of Creutzfeldt-Jakob disease occurring in an isolated tribal group that practiced endocannibalism. These didn't go out and kill missionaries. These were people who ate their loved ones. This is to maintain, just to give them eternal life. And so it was a ritual of mourning and a ritual of homage to their relatives that they ate them, including the brains. So that appeared to be an epidemic that was started in just that way, as seeding into a particular situation.
And that epidemic disappeared when the ritual was ended. But what was the transmissible agent that caused Kuru? And how did cases of other spongiform encephalopathies arise? The assumption was that a virus was involved, but no one could find it.
I was a virologist before I went into neurology, and the idea that this non-inflammatory disease with an incubation period of 4 years might be an infectious agent just didn't make sense in my world, as it was in those days.
People were searching for the virus. People thought there was probably a virus there, but there had been no data that would convince a reasonable skeptic that there was a virus causing this transmissible disease, scrapie, and then, of course, Creutzfeldt-Jakob disease at the time I entered the picture.
During a series of experiments over several years, Dr. Prusner and his colleagues developed techniques that revealed the infectious agent lacked a nucleic acid and couldn't be a virus.
There was no evidence for a nucleic acid. All the evidence pointed toward a protein. It allowed us then to isolate that protein, so we now could physically study the protein. No one had ever known about this protein before, the prion protein, or PRP.
Dr. Prusner coined the term prion to denote a protein infectious particle. Now we know that normal prion proteins are abundant in the body and are found on the membranes of many cells, including neurons. As with other proteins, they're produced in the endoplasmic reticulum, processed in the Golgi apparatus, and transported to the cell surface. And as with many other surface-bound proteins, they're engulfed by endocytosis and degraded within lysosomes. The normal cellular prion proteins are designated by the term PRPC. The three-dimensional structure of these proteins is predominantly made up of alpha helical configurations. In prion diseases, that configuration changes to become predominantly beta-pleated sheets. The abnormally folded prion molecule is designated PRPSC, because it was first identified in scrapie-infected sheep. An abnormal prion molecule can induce other normal prion proteins to adopt the pathologic configuration, thus leading to a geometric increase in the number of abnormally folded prions. These molecules aggregate together. They're resistant to proteolytic digestion, and so they can accumulate within lysosomes or on the surfaces of the cells. They're also deposited in the extracellular space and can be stained with an immunostain using an antibody directed against the prion protein. In this section, the brown areas represent deposits of prion protein in a patient's brain.
That protein, when it accumulates, is what causes the disease. The malfunction of the nervous system is really the result of PRPSC accumulation.
One of the great paradoxes about these diseases, which is unique, is that they're sporadic, like sporadic CJD, they're transmissible, like iatrogenic CJD, and yet they're inherited as well. And that's always been a major problem to understand. And one of the attractions of the Prion hypothesis is that it unifies all these different types of CJD by explaining it all due to instability in the protein.
The discovery that prion diseases can be genetic, they can be infectious, and they can be sporadic is a whole new disease paradigm that no one understood before this was teased out.
A spontaneous change in conformation sets off the process that leads to sporadic prion diseases, and those make up the vast majority of cases. In the familial forms, a mutation in the prion protein gene is responsible. The acquired or infectious forms are induced when abnormal prions from the outside gain access to the CNS. Those include iatrogenic CJD, Kuru, and variant CJD. Within the different forms of prion disease, there's also a range of clinical features, which may be explained by variations in prion protein structure. In the next section, we'll explore how that happens in sporadic and familial prion diseases.
What's your favorite? There you go.
During the course of CJD, virtually all patients have profound cognitive decline. The vast majority exhibit myoclonus, and most have ataxia or pyramidal tract signs. Other symptoms, such as visual problems, seizures, and sensory abnormalities, are less common, and all symptoms may vary in their severity and time of onset. That variation appears to be related to individual differences in prion proteins.
If you use molecular characteristics, such as the genotype of the prion protein, that is genetic feature, the gene of the prion protein is different in normal individual. You and I probably have a different prion protein gene.
The prion gene is on chromosome 20 and codes for a protein containing approximately 250 amino acids. We can represent the linear structure of the prion protein without its three-dimensional folding, like this. There are many sites along its length where its structure may be modified. One type of variation is polymorphism, the possibility that more than one amino acid could be present at a particular position in a normal protein. Polymorphisms don't cause disease, but the polymorphism at position 129 has been associated with different clinical presentations in people who develop prion disease. A normal prion protein may have either methionine or valine at that position. Everyone has 2 copies of the prion gene, one from each parent, and each one may code for either methionine or valine at position 129. So some people will have methionine in both proteins, some will have one of each, and some will have valine in both. Although those don't cause CJD, they are associated with modifications in the presentation and course of the disease.
We observed that the patients that have the amino acid methionine tend to have a disease different from those who have the amino acid valine.
The distribution of the 129 polymorphism differs among populations. In Caucasians, the group for which we have the most data, 51% are heterozygous, 37% have 2 methionines at position 129, and only 12% have 2 valines. In Asians, MM predominates, and in Africans, MM and MV are seen in approximately equal numbers. Another type of variation involves different ways that the abnormally folded prions resist enzymatic digestion. We can identify that by the migration pattern of the protein residues on Western blot analysis. This represents the pattern seen with normal prion proteins. If normal prion proteins are subjected to digestion with the enzyme proteinase K, they're completely digested, and the Western blot reveals no residual material. But the misfolded scrapie prions associated with disease resist digestion in 2 characteristic ways. In one form, the protein is digested up to amino acid 82, leaving the remainder intact. In another type, digestion occurs up to amino acid 97, leaving a shorter remaining fragment. The two different length fragments have different migration patterns on the western blot, so they can be distinguished that way. The longer fragment is called type 1 and the shorter fragment type 2. So there are 6 possible combinations that might be seen in sporadic prion disease. An MM patient might have type 1 or type 2, an MV patient might have type 1 or type 2, and a VV patient might have type 1 or type 2. Dr. Gambetti and his colleagues related those combinations to different sets of clinical features in more than 600 patients.
When I say different means patient in which the disease presented at a different age, had a different duration, had a different presentation. In other words, signs of the disease were different when the disease started, and the pathology was different.
This chart shows the possible combinations and their frequency of occurrence. Patients who are either MM1 or MV1 make up the majority, and they typically have the shortest duration, with rapidly progressive dementia, early prominent myoclonus, and characteristic EEG findings. The prion deposits, brown in this immunostained section, are found in a diffuse stippled pattern around nerve cell bodies and their processes, in a pattern that has been referred to as synaptic. In contrast, MV2 and VV2 have early prominent ataxia and usually don't have the typical EEG findings. They both have plaque-like deposits of protein in the brain, as shown in this immunostained section. In addition, patients with MV2 have amyloid plaques in the cerebellum that resemble those seen in Kuru. MV2 is also associated with the longest average duration, about 17 months. VV1 is rare. It has the earliest onset, typically in the mid-40s, and aphasia is a prominent symptom. There are 2 clinical forms of MM2. The vast majority of MM2 patients have cortical pathology and dementia. Another group of MM2 has mainly thalamic involvement and a clinical picture dominated by insomnia and autonomic and psychomotor symptoms, similar to one of the hereditary forms of prion disease, fatal familial insomnia. Not every case fits precisely into one of these subtypes, but they do explain much of the clinical variation in sporadic CJD.
This classification, in my mind, really makes it clear that you can expect different presentation, and the different presentation has a molecular basis. So there is actually an explanation for this difference.
And although the polymorphism at position 129 doesn't cause prion disease, it appears to influence susceptibility, with heterozygous MV individuals being relatively protected. More than half the general population of Caucasians has the MV genotype, but they make up a much smaller proportion of patients with sporadic prion disease, while MMs are greatly overrepresented. We don't know what causes the original misfolding of a previously normal prion in a patient who develops sporadic CJD, but about 10% of CJD cases are inherited. That includes Tom and his daughter and several members of Dina Simpson's family.
Our family has the familial form of CJD, and we've lost 12 members now over 5 generations, the first one hitting my generation just last year.
Dina's mother developed symptoms in May 1998.
I had to tell her that she was dying of the family disease, which was a very, very difficult thing for me to do. And I looked at her and I said, "You know the outcome." And she said yes.
In addition to Dina's mother, 11 other family members have died of CJD. 2 others are thought to have died of it, but there was no pathologic confirmation of the diagnosis. And 2 more, so far, are known to carry the mutation. There are several known mutations of the prion gene that result in the substitution of an incorrect amino acid, which can lead to misfolding of the protein.
Unfortunately, the majority of the mutation have a very high penetrance that vary between 90%, 80%. That is, virtually all the carriers of the mutation eventually develop the disease during their lifetime.
The Simpson family has the most common mutation at position 200. Normal prions have glutamic acid at that position, but the mutation results in the substitution of lysine. Only one mutated gene is necessary in order to produce abnormal prions that will become misfolded, so the disease has a dominant pattern of inheritance. 50% of children will carry the gene. Even before symptoms appear, the gene can be detected by a blood test, just as in other hereditary illnesses. It's important to perform the test, but the results may have difficult implications.
I was tested, I found out I was negative. And that result wasn't easy to take either, because then I looked at myself and said, why was I so lucky when I'm going to watch my siblings go through this very thing?
Another common mutation is at position 178, and it illustrates the interplay between mutations and polymorphisms. The normal prion protein has aspartic acid at position 178. If that mutates with substitution of asparagine, the prion will become misfolded, causing disease. But the type of disease will be determined by the polymorphism at position 129. If the mutated prion has valine at position 129, the patient will develop familial Creutzfeldt-Jakob disease. But if there's methionine at position 129, the patient will develop a different disorder, fatal familial insomnia. Familial CJD, like sporadic CJD, has spongiform change predominantly in the cortex with some involvement of the deep gray matter. Fatal familial insomnia, like sporadic fatal insomnia, has marked neuron loss and atrophy in the thalamus and only slight involvement of the cortex. Several possible mutations may be associated with an extremely rare hereditary disorder, Gerstmann-Straussler-Schenker disease. The symptoms are variable, but they usually include ataxia, dysarthria, and eye movement disorders. Familial forms of CJD and fatal familial insomnia are clinically indistinguishable from their sporadic counterparts.
The most important thing to understand about genetic CJD is that it may present entirely looking like sporadic CJD. It may not be clinically any different. And you might think that because it's an autosomal dominant disorder that there must be a family history. Well, that's not so. In a significant proportion of people who present with genetic CJD, who have an abnormal mutant gene, they do not have a family history.
That was the case with Tom. His daughter had been diagnosed with CJD and there was no family history. She was discovered to be carrying a mutation, and it was only after she died that he began to show symptoms.
The important point is that if you have somebody in front of you that you think has CJD, then if you want to be sure it's not genetic CJD, you have to do genetic testing. That's the only way of being absolutely sure.
Both sporadic and familial CJD can be difficult to diagnose, especially early in the disease. In the next section, we'll consider the clinical presentations and differential diagnosis of Creutzfeldt-Jakob disease.
That might help you to score a few extra points, take some pressure off you possibly.
In its best-known forms, CJD has characteristic symptoms and dramatically rapid progression. This man was a talented teacher, chosen to present a broadcast to help students prepare for final exams.
I'm a school teacher. I'm used to talking to groups of people, not to lights, TVs, cameramen, guy waving at me, okay?
But within a short time after his symptoms began, he was bedridden and unable to communicate. He also exhibited myoclonus, seen here as he was trying to chew, and startle myoclonus when there was a loud noise.
Ooh, what was that?
Side rail.
If we see a patient who is dementing very rapidly and has involuntary movements of the limbs, then the alarm bells should sound. So rapidly progressive dementia with myoclonus is the paradigm mechanism of presentation, and there are a few other conditions that actually truly mimic that.
But most patients who present with rapid confusional states don't have CJD. The possible causes include infections, vascular disease or vasculitis, tumors or perineoplastic syndromes, metabolic abnormalities, and primary neurodegenerative diseases. It's essential to be sure that you don't miss any treatable conditions, so the workup can be very lengthy.
I think sometimes, in my experience, families are quite angry that the diagnosis has been delayed. But the reason for that is that this is not an easy diagnosis to make in some cases. Often it can be very difficult in the early stages because there are far more likely alternative possible diagnoses.
My frustration with this whole disease was having no answers. I figured we took him to the hospital, he'd be fine. They'd find it, he'd be okay.
It's very difficult for a neurologist because you're faced with a patient who is declining rapidly, often with severe neurological problems, and the tests tend to be normal. A normal scan, normal CSF, and unless you know something about CJD, you may not think to look at the MRI scan specifically for the changes in the caudate putamen. You may not order a 1433 test, and you're faced with a deteriorating patient without any particular positive test that has been done during the hospital admission. It's very difficult.
Those tests, the MRI and the 1433 test on CSF, along with the electroencephalogram, may provide reliable information. Several studies have pointed out the utility of MRI scans. In particular, the fluid-attenuated inversion recovery and diffusion-weighted images may reveal ribbon-like intensity in the cortex, which corresponds to the spongy change seen under the microscope. The basal ganglia may also show characteristic hyperintensity. In a recent report, among 40 CJD patients, the FLAIR images and DWI showed abnormality in both the cortex and the deep gray matter in 68% of the patients. That combination was not found in any of 53 non-CJD controls, including patients with Alzheimer's disease, frontotemporal dementia, Lewy body dementia, or mild cognitive impairment. Electroencephalography also offers help in diagnosis. The World Health Organization has established EEG criteria for the diagnosis of sporadic CJD, including strictly periodic sharp wave activity that continues for at least 10 seconds, bi- or triphasic morphology of the complexes, and generalized or lateralized distribution. Combination studies indicate that ribbon-like areas of hyperintensity in the cortex in diffusion-weighted images correspond to the localization of EEG sharp wave activity. The DWI changes have also been reported as an early diagnostic marker, preceding the appearance of EEG abnormality. There is no simple lab test on blood or on CSF that can detect CJD, but the CSF may contain a high level of 1433 protein, which is a normal constituent of neurons. Unfortunately, that's not a specific test.
It can only be interpreted in the context of rapidly progressive dementia. If you try and use the 1433 test as a screening test for dementia, it really is not very helpful at all. It has to be applied in the right clinical context.
These tests can help establish the diagnosis of probable CJD, but they may not be useful early in the course.
People talk about the EEG and the MRI changes being there in the vast majority of patients. Yes, if you look at them serially, they are. If you have multiple time courses, you'll find the abnormality there. But if you're the first person who sees them, if you see the patient early on, those may all be absent. All those laboratory findings that may turn positive later.
But might there be a way to suspect that a patient has CJD earlier in the course? Initial symptoms often mimic those of other conditions, and patients don't reach specialists until late in their illness.
The patients I see with this disease, in large part, majority of them, have had months of a very rapidly, steady, progressive dementia. Almost all have movement disorders by this time. They usually have myoclonic jerking, which is the commonest movement disorder they develop, but often late in the disease. When you walk in the door and you close the door, they sort of pop off the bed with this terrible myoclonic jerking. They have MRIs that show abnormalities. They have abnormalities in their spinal fluid. They have abnormal EEGs. That's Creutzfeldt-Jakob disease. That's not hard to diagnose. Now, 6 months before, when they showed up in their doctor's office and said, I'm having a little trouble sleeping, or my backhand wasn't so good on the tennis court this morning, or I have this trouble remembering guys' names. You know, they can't make a diagnosis. It starts out as in this insidious way, and very often with the most general symptoms that all of us have experienced.
He forgot his first appointment. He didn't show up. And I don't know if that's relevant or not. I don't know if that was just a fluke or if that's, a look back at his disease. But, the first note in the chart is patient forgot his appointment, rescheduled.
Tom's daughter also had nonspecific early symptoms. She had some difficulty with coordination, the same sort of chief complaint that her father later had. But she was also diabetic.
She had been evaluated by a number of physicians, and their concern was that this was a peripheral neuropathy related to her diabetes. and that she was having some sensory symptoms related to the diabetes and the peripheral neuropathy, and this was causing her to be a little clumsy, so that all of the motor symptoms were diabetes, sensory and motor systems were diabetes related. They didn't have a good account of her cognitive disturbance, but in fact, we're not convinced that there really was much of a cognitive disturbance, because when they did, for example, the mini mental state examination, she did well. She was pretty normal.
But the mini mental state exam isn't sensitive to the early behavioral changes that may occur in CJD. In retrospect, both Tom and his daughter exhibited personality changes before other symptoms were noted.
In the very beginning of the illness, the things that were noted by the families was, my daughter, my husband is not behaving quite appropriately. And this is something that I think that clinicians are often relatively inattentive to. These patients, when they were first starting to show abnormal behavior, would have been terrific on the mini mental state examination. For one thing, it doesn't say anything about social comportment, which is a major element of the dysfunction and the symptoms in Jakob-Creutzfeldt disease.
Tom's wife noticed some personality changes months before the diagnosis was made.
And these are, in this case, as they often are, very subtle. So he simply wasn't himself. He was a little bit overly jocular. You could use the term inappropriate, but it seems too strong, because these were very minor things. It was just that he was perhaps a little less sensitive to other people's comments and feelings than he probably should have been.
It would appear to be a rudeness on his part, like he was bored with people.
Many patients exhibit personality change as an early sign.
He had depression. He was a very sweet and gentle person. He had anger, which was very unusual.
His roommate said he was irritable. The kids across the street were annoying them, and that was not like my son, because he loved kids. Usually when they were out, he'd go and throw a ball with them or something.
Penny Humphrey began quarreling with her sister, who had been her best friend.
I sent her an email and I said, I'm not sure what's going on right now, but I just want you to know that whatever has happened with us, I'm here for you. I care about you. And if you need me, I'm here. And being the reporter that she was, having an incredible command of the English language, she wrote back to me, and it was very disjointed, lots of misspellings, grammatical errors. And she basically said, oh, I'm fine.
Over the next 2 years, she developed a wide range of physical and cognitive symptoms. The diagnosis of probable CJD was finally made 2 months before she died, but it might have been suspected much sooner. Personality changes certainly aren't unique to CJD, but their early appearance may be a clue.
They can certainly be seen very early in Alzheimer's disease. Probably a bit right at the beginning in Jakob-Creutzfeldt, as opposed to Alzheimer's, where memory impairment really does predominate early.
Tom and his daughter also had characteristic motor symptoms. They both had diabetes, but these symptoms were not related to diabetic neuropathy.
By the time we saw her, she had some rather distinctive clinical features. She had a clear-cut cerebellar deficit, both with respect to her gait and in her hands, so that with finger-nose-finger testing, for example, she was moderately impaired. She was able to feed herself and do activities of daily living, but less well than she could before. Her writing, for example, was really rather messy, disordered.
That also happened to her father's handwriting. And how would you describe that signature?
Sloppy as hell for me.
Here, is that
it's sloppy as hell for him.
Sloppy as hell.
He also had trouble with other motor tasks as well as cognitive impairment.
That's pretty good today.
Yes? Why did you do that some other time?
Yeah, and you were dropping the pen.
It was really more of a pyramidal or cerebellar deficit in the motor performance, and that's not typical of any of the primary degenerative dementias early on.
Even though it was discovered that his daughter had a familial form of CJD, a diagnostic workup was undertaken to look for treatable diseases.
We did a variety of studies to try to exclude other treatable conditions, including Lyme disease and various other infections, and we just didn't find any evidence for those. We're left with a presumptive diagnosis, the clinical diagnosis.
The diagnosis of definite CJD requires examination of tissue at biopsy or autopsy, or a positive test for prions on Western blot. A patient can be classified as probable CJD if there's progressive dementia, typical findings on EEG, and at least 2 of these neurologic abnormalities: myoclonus, visual impairment, cerebellar signs, pyramidal or extrapyramidal signs, or akinetic mutism. The criteria for possible CJD are similar, with a duration less than 2 years, but without supporting EEG data. A patient who has possible CJD may be regarded as probable if there's a positive 14-3-3 test. Once a diagnosis of CJD is made, we have to contend with the fear factor. In the next section, we'll look at the ways prion diseases can be transmitted and the ways that they can't. They're called transmissible spongiform encephalopathies, but just how transmissible are they?
Now, I appreciate that sporadic CJD is not an infection, but you can, in principle, catch sporadic CJD, and certainly some forms of the illness, like variant CJD, clearly have been and are transmitted by some form of ordinary process in ordinary life. And I think that people have become primitively afraid of infectious disease.
This is not a communicable disease in the usual sense. Is it transmissible? Yes. We as doctors have transmitted it. We've done it with growth hormone, we've done it with dural grafts, we've done it with unsterile surgical tools. And so that has happened. And that, of course, makes people say, my God, it's infectious. Doctors as well as patients.
Iatrogenic transmission is well known but uncommon. It happens when contaminated material is introduced directly into a patient. For instance, neurosurgical procedures sometimes involve placement of a dural graft. Dura from a donor with CJD can transmit the disease, and since the abnormal prions are inoculated directly into the nervous system, it's not surprising that the clinical picture resembles usual sporadic CJD.
And what is the hallmark of these cases is, of course, that they've had a human dura-mater graft. And therefore, if you want to identify such cases, you have to have a good background history and know that they have had a human dura-mater graft, which is not always obvious. It may require some inquiry.
Turns out that you have a risk factor if you've had a dura-mater graft, and my husband had a graft for his brain surgery in 1979, but not a single person knew that he should be considered to be at risk for this.
When CJD is transmitted by human growth hormone injections, it reaches the brain by a hematogenous route and has a different clinical pattern.
And they tend to present with a gradually increasing cerebellar ataxia. And they usually do not have dementia or cognitive dysfunction in the early stages. And usually such cognitive dysfunction occurs late and is relatively mild.
2 other acquired prion diseases, Kuru and bovine spongiform encephalopathy, have remarkably similar symptoms. Their mode of transmission is the same: consumption of CNS material from another individual who had the disease.
Bovine spongiform encephalopathy, mad cow disease, got started by either a sheep or a spontaneous cow. We don't know which, but most people think sheep with scrapie getting into the rendering process where meat is recycled and fed as food back to livestock. Then got into the cattle, and then as cattle were harvested and 50% of them go back into rendering, and all this became amplified, much as in the society among the 4A people of New Guinea.
And some people who ate products made from BSE-infected cows developed a human form of the bovine disease, called variant CJD. The United Kingdom had an epidemic of BSE among its cattle, which ended after contaminated food supplements were banned. That was followed by an outbreak of variant CJD in humans. Charlene Singh was one of those patients. She was the first person with variant CJD seen in the U.S., but she had acquired the disease while living in Britain. Typical of variant CJD, her first symptom was depression, and it was not thought that she had a neurologic illness.
We noticed some difference in her behavior, forgetfulness, fatigue, which we thought was depression. She just finished college, university, and we were wondering if she was depressed, not finding the job that she wanted. And so we took her to the doctor. They treated her for depression.
This illness, when it first presents, is very often diagnosed, for example, as depression, and indeed quite reasonably so, because if you have somebody, for example, who's 20, who comes along to see their doctor with a history of not sleeping very well for a few weeks, being off their food, being tearful, being irritable, not wanting to go to work, sitting at home and not having any drive or enthusiasm for things, loss of sexual interest and so on, and nothing else, then that would be very typical for some form of developing depressive illness. And of course, such illnesses are extremely common.
Psychiatric signs were showing up. He became very scared in a situation where it was unlike him as an individual, so we knew that something was wrong. We knew that some form of impairment had taken place, but none of us knew what it was.
Jonathan was, as I say, a keen soccer player, and we noticed a change. He was trialling for the under-18 international soccer squad in Northern Ireland. But the boy playing on the soccer pitch that I saw one evening didn't care. Johnny Sims, this is not the real Johnny Sims.
In variant CJD, the neurologic findings appear later.
After about 3 months, we noticed our right hand was shaking, the fingers were shaking, and we said, this can't be depression, even though we were treating for depression. And by the middle of January, we noticed she was walking and she would stumble from her right leg.
At some stage, after this illness develops, they begin to develop neurological problems. For example, and most typically, cerebellar ataxia. And there may be other features like visual disturbances, sensory symptoms, pain, and so on.
Variant CJD affects a younger population than sporadic or familial CJD. This graph of data from the UK shows that the typical age at death of sporadic CJD patients is in the mid-60s, while that of variant CJD patients is in the mid-20s. In variant CJD, as in bovine spongiform encephalopathy, the route of infection is oral, and in addition to the CNS, abnormal prions may also be detected in the lymphoid tissue of the alimentary tract. The diagnosis may be supported by a biopsy of the tonsil. This is a section of tonsil from a patient with variant CJD. It's been stained with an immunostain that shows the abnormal prion proteins dark brown. In the brains of patients with variant CJD, the deposits of prions are dense and widespread, and they're referred to as florid plaques. There's also a characteristic MRI appearance. While sporadic or familial CJD patients often have hyperintensity in the caudate and putamen, the variant CJD patient is much more likely to exhibit hyperintensity in the thalamus, a finding known as the Pulviner sign. The variant CJD cases received a great deal of publicity because of their link to contaminated cattle. But in spite of extremely widespread exposure, the number of variant CJD cases in the United Kingdom each year, shown here in green, was never as high as the number of sporadic cases, shown in red.
We don't really know why these particular individuals became infected and why the disease so far, and very fortunately, has affected a relatively small number of the population.
One clue about susceptibility might lie in the methionine-valine polymorphism. As we've seen, MM homozygosity is much more common in sporadic CJD patients than it is in the general population. And variant CJD presents an extreme case. All the symptomatic patients so far have been MM. Variant CJD has been transmitted to 3 people in the United Kingdom through blood transfusions, and the safety of the blood supply has been brought into question.
In the UK, for example, where nearly all the population in the 1990s and 1980s in particular were exposed to BSE, some of us, a proportion of the population, will be incubating variant CJD, and there is no way of identifying who is incubating the disease, and no precautions can be taken against those individuals because we don't know who they are.
In contrast, there's no evidence that sporadic CJD has ever been transmitted by a blood transfusion.
First of all, in case control studies, having received blood transfusion in the past does not raise your risk of coming down with Creutzfeldt-Jakob disease. There are multiple studies that show that. Secondly, the Red Cross and CDC have done a look-back study. They've taken patients who've developed Creutzfeldt-Jakob disease who have previously been blood donors and then followed up that blood to look at hundreds of patients who've received that blood. Not one of them has developed Creutzfeldt-Jakob disease.
In North America, a prion disorder called chronic wasting disease is spreading among deer and elk, and it is natural to wonder whether it could spread to humans. The National Prion Disease Pathology Surveillance Center is especially watchful for any sign of animal-to-human transmission.
The central mission of the National Prion Disease Surveillance Center is to promptly identify the cases that can really present a public health threat to United States population. And these are the cases of variant CJD and of possible human version of chronic wasting disease, the prion disease of elk and deer. So in order to be able to identify these cases, we have to examine by tissue analysis as many cases as possible.
The CJD Foundation plots each reported case on a map. The pins are color-coded according to the year of the report. Generally, sporadic CJD strikes about 1 person per million per year. Occasionally, there may be a cluster of cases that seems unusual, and the question arises, could these have come from a contaminated source, such as infected deer? The Surveillance Center has examined tissue from 27 hunters who had CJD.
And so far, we have not found any of the so-called hunters, individuals exposed to the chronic wasting disease that had, in which the scrapie prion protein reproduced the characteristics of the scrapie prion protein associated with chronic wasting disease. So we have no evidence of transmission of chronic wasting disease to humans so far.
Prion diseases are frightening, but we must be aware and make others aware that they are not contagious in the usual sense.
Do you think people are afraid of this disease?
A lot of people are fearful of this disease, naturally. When you tell someone that you think you have a possibility of having CJD also, well, everybody sort of seems just to shy away from you at first.
People are frightened of CJD and of infection. However, it's quite clear, and it's very important for families, that we have no evidence that sporadic CJD, or in fact any other form of CJD, is transmissible from person to person through social contact. So being in contact with an individual with CJD is not a risk, and therefore they don't need barrier nursing in hospitals where sometimes excessive precautions are being taken, which can be very distressing.
All the attendants that came in to attend to him, they'd all put on a disposable schmuck and a face mask and gloves, and we're all sitting there in our street clothes, you know.
Next, we'll consider the impact of CJD on patients' families and the resources available to help them cope.
You hear those 4 words you never want to hear from a physician's mouth: no treatment, no cure. The most frustrating thing about the whole ordeal was the fact that I felt helpless, that I could not help my son.
I think that all you can do when you have a patient with CJD is tell the family how upset you are, how sad you are that this has happened, and that the likelihood of the patient having CJD is very high. That means there is no treatment. That means they will certainly die.
Dealing with the family is, needless to say, a very difficult and delicate issue. Basically, what you're saying to someone is that your loved one has a disease that will kill them in a relatively short period of time, and we have absolutely nothing useful to do.
CJD Foundation.
The helpline at the CJD Foundation receives more than 100 calls a month from people who need information and support.
I have referred people to the Creutzfeldt-Jakob Foundation, and they really go to bat for people. They give them information, hard scientific data about what is a concern and what is not, and allow them to identify people who are susceptible to reason.
The fact that more and more families are calling the CJD Foundation indicates how successful the CJD Foundation has been in this very difficult task.
The CJD Foundation and the Surveillance Center work closely to support each other's missions. The Foundation also offers information to anyone interested in CJD, medical professionals, patients' families, or the general public, by phone, through chat rooms, or on their website at cjdfoundation.org. When a patient with probable CJD succumbs to the illness, examination of tissue is very important, and physicians and families should be aware of the availability of autopsy and the services offered by the National Prion Disease Pathology Surveillance Center.
Tissue examination is really the way to establish the diagnosis. But then there is the other aspect, a very important aspect. Tissue is absolutely necessary to establish with accuracy the type of prion disease, and that's what we want to know.
To provide the most useful information, the center should receive frozen brain samples as well as standard fixed tissue. Ideally, that would mean half the brain fixed and half frozen. In order to make submitting a specimen as simple as possible, the Surveillance Center will send you all the equipment you need for packing and shipping. The Surveillance Center will also help with the arrangements for an autopsy through its National Autopsy Referral Network, and will cover costs related to the performance of an autopsy. For further information, the internet address of the Surveillance Center is cjdsurveillance.com. Many families are mistakenly told that you must wear gloves to touch a patient, that having an autopsy performed involves extra expense or requires that the body be cremated, that bed linens or anything a patient touches must be burned. Those are just some of the misconceptions that the CJD Foundation helps correct.
We work with nursing homes, with hospices, with funeral homes. Anytime there's a problem and they've called us, we either can answer it, we get the answer, or we refer them to some place where they can get the answer, and we follow up. We always follow up.
You like to think that you could make at least what is a terrible situation a bit better, or at least not as bad as it might be, just by the way you deal with it and by being able to give people information and answer the questions and relieve their uncertainties and fears about it.
So science has taught us to understand what's happening to a patient with CJD, to make sense of these diseases, and how to provide support for the families. What we need next, and what's on the horizon, are the scientific advances that will enable us to control prion diseases through early diagnosis and ultimately effective treatment.
I think the more realistic solution would be, practical solution would be to learn how to diagnose these diseases very, very early. And that, I think, could be done.
That was the charge to the Institute of Medicine Committee on Prion Research.
The main goal of that, as stated in the congressional bill, was to find a test for the disease. And heaven knows everybody would love to see that.
What we're working on very hard here is a blood test for CJD. And Yuri Safar, who's been working with me for 10 years now, is making progress. Are we there yet? I don't think quite. Are we encouraged by what he's finding? Extremely encouraged.
If we could develop that, then there's a possibility that we could develop novel therapies that might prevent prion protein accumulation and therefore prevent the disease happening at all.
I don't want another family to go through this with no answers, and perhaps with an autopsy with my son, it'll provide answers. It'll some way find something that could stop the disease, give an answer.
I would love for in the future when people come down with this disease that their loved ones don't hear those 4 words that I heard. No treatment, no cure.
There's nothing you can do but watch this person waste away. You can tell jokes, you can play music, you can feed her chocolate ice cream, but in the end, she's going to be gone.
You're not alone, and we're all in this together. And the frustration, the fear, the pain, the sadness that you feel is very normal, and there are other people out there who are experiencing this very same thing that can offer you the support that you need.
I gave him the dignity that was important for me to see that he had in his final moments. And I told him how much I loved him, and I told him how much I thanked him for the time we had together.